Welcome to the deep dive. We're tackling a really fascinating and important topic today.
Mhm.
What happens when radiation therapy, this powerful tool against cancer, actually has longer term effects on healthy tissues?
Right, these delayed radiation injuries, things like damage to soft tissue, even bone.
Exactly. And we're going to explore a potential key player in managing these complications. Hyperbaric oxygen therapy or HBO?
Yeah, definitely.
Yeah.
Our main source here, it's a really detailed chapter from a medical manual focused on hyperbaric medicine indications.
Okay.
So think of it as a deep look at the science behind HPOs for these specific injuries, how it's being used right now, and maybe even where things are heading, with research.
So, for you listening, your mission basically is to get a clear picture of these delayed radiation injuries. We want you to understand the evidence for HBO as a treatment.
You get a sense of where the research is still active, where maybe scientists don't fully agree yet?
Right. And we'll try to break it all down without getting bogged down in, super technical jargon. Ready to jump in?
Absolutely. Let's kick off with something fundamental. Radiation injury isn't just like an instant thing. It happens over time.
Right. The manual lays out these different time frames. You've got the acute injuries during or right after treatment,
Uh-huh.
then subacute, maybe weeks or months later. But we're really zeroing in on the delayed ones, sometimes called late radiation tissue injuries or LRTI.
Exactly. And these LRTIs, they're distinct because they usually don't show up for at least 6 months after the radiation. Sometimes it's years later.
Yeah, years. And what's interesting, sometimes they seem to be triggered, like by another injury or maybe surgery in that same area.
That happens, yeah. But the manual also points out sometimes they just appear seemingly spontaneously without a clear immediate trigger.
Which suggests the damage is still kind of evolving underground, so to speak.
Precisely. The chapter uses this term, consequential effects, to describe how these harmful changes just keep developing in the tissues. It's not static.
Now, radiation therapy itself, it's gotten way more sophisticated, right? Techniques like IMRT intensity modulated radiation therapy, they aim to be super precise.
They do.
So you'd think that means fewer of these late problems.
And that's the goal, absolutely. And IMRT has helped reduce the overall rate of LRTIs in many cases. But the manual makes a really interesting counterpoint.
Oh,
It suggests IMRT might actually possibly increase the risk of certain specific types of delayed injuries in particular places.
huh, like what?
Well, the big example they give is mandibular osteoradionecrosis, ORN. That's bone death in the jaw. It seems to potentially be happening more often with IMRT when treating head and neck cancers.
Wow, okay, that's really counterintuitive. More precision, but potentially a different kind of delayed risk in some spots.
Yeah.
All right, so we know what they are, when they happen, but what's going on biologically, like deep down?
Well, the manual is clear that the exact biochemical stuff is, complex and not fully mapped out. But a key factor, a really central piece, seems to be damage to the tiniest blood vessels.
The capillaries and such.
Exactly. It's called obliterative endarteritis. Basically, the radiation damages these small vessels. They get blocked up, scarred
And that restricts blood flow.
severely, which leads directly to tissue hypoxia, just not enough oxygen getting to the tissues in that area.
Okay, so damaged plumbing leads to oxygen starvation. What happens then?
Well, this chronic lack of oxygen kicks off what's called a fibroatrophic process. It's kind of a double whammy.
Eupibroatrophic. Break that down.
Okay, so fibro refers to fibrosis.
Hmm.
The body tries to repair things by laying down excessive scar tissue. But atrophic means there's also wasting away, degeneration of the actual healthy tissue structure,
So bad scarring and tissue breakdown at the same time.
pretty much. And part of this involves losing stem cells, the cells critical for repair, plus damage to the connective tissues, the sort of scaffolding of the area.
And the manual mentions other biochemical actors involved too, little signaling molecules.
Yeah, cytokines, things like TGF-beta, various interleukins, TNF-alpha. These are signals that, in this context, kind of keep the inflammation and that scar tissue formation going long-term. It's a persistent damaging signaling loop.
Got it. So radiation hits the blood vessels, cuts off oxygen, triggers this destructive scar and decay cycle, fueled by ongoing inflammation signals.
Okay.
Now, let's bring hyperbaric oxygen, HBO, back in. How does it potentially interrupt this whole mess?
The thinking, based on the manual, is that HBO works through at least three main mechanisms. The first one is kind of the most obvious.
More oxygen.
Exactly. Breathing pure oxygen under higher pressure dissolves much more oxygen into your blood plasma.
Yeah.
This superoxygenated blood can then reach those starved hypoxic tissues.
Right.
And this promotes angiogenesis. That's the growth of new, healthy blood vessels, getting more oxygen in and helping rebuild the plumbing.
Okay, so tackling the hypoxia and the blood vessel issue directly. What else?
Second, there's evidence suggesting HBOs can help reduce that excessive fibrosis, the scarring. It might help remodel the scar tissue. And third, it seems to help mobilize stem cells. It encourages the body's own repair cells to, get moving towards the damaged site and differentiate, become the cells needed for repair.
So it's not just passive oxygen delivery, it's actively stimulating the body's repair toolkit.
That's the idea, yeah. It's
Right.
trying to restart or boost those natural healing processes that the radiation damage shut down.
And the manual says there's actual evidence for this, not just theory.
Well, yeah. There are animal studies, plus case reports and series in humans, suggesting HBO can improve vascularity, the blood vessel density, in tissues that have been irradiated.
Okay.
And there's also data indicating it can help reduce that problematic collagen deposition, the stuff that makes up the dense scar tissue.
All right, so we've got the why and somehow. Let's get specific. Mandibular radiation necrosis, ORN, that jawbone problem, seems like a really big focus for HBO. Why is that?
It is. ORN is just a really nasty, debilitating complication. It can cause severe pain, infection, fractures, difficulty eating.
Yeah, it sounds awful.
And HBOOs has been used to try and treat it for, over 4 decades now. So there's a long history. The risk, as you'd expect, is tied to the radiation dose the jawbone got.
Higher dose, higher risk.
Definitely. And another major trigger, the manual really emphasizes this, is getting teeth pulled in a jaw that's already been radiated. That trauma can kick off ORN.
Ah, that makes sense.
No.
Disrupting already fragile tissue. Now, the manual mentions Dr. Robert Marks and his protocol. What was significant there?
Dr. Marks really formalized an approach. His protocol usually involves a set number of HBO dives, as they call them, before any surgery to remove the dead bone,
Right.
and then more dives after the surgery.
Okay, sandwiching the surgery with oxygen care.
Exactly.
Yeah.
And he also developed a staging system, which is widely used, to classify how severe the ORN is. This helps guide treatment. Is it mild, moderate, severe?
So is the Marks protocol basically the standard now?
It's been hugely influential, no question. And lots of studies, especially earlier ones, case series, reported really good outcomes. Better healing, less pain.
But there's a but.
Yeah. It's important to say some more recent randomized controlled trials, that sort of highest level of evidence they've shown, less clear benefits. Some even questioned if HBROs is always needed, especially compared to surgery alone in certain cases.
So the debate continues.
It does. It highlights that while Marx's work was foundational, we're still figuring out the optimal protocols, exactly which patients benefit most, and when in the process HBO is most crucial.
Does the manual touch on whether you always need HBO before the surgery for, say, smaller ORN lesions?
Yes, it does raise that point. Some experts argue that for less severe cases, maybe conservative management, meticulous cleaning, mouthwashes, maybe antibiotics might be enough initially,
Yeah.
perhaps avoiding pre-op HBOs in those specific situations.
What about the really severe cases, the ones needing major reconstruction, like free flap surgery, where they move tissue from, say, your leg to rebuild the jaw?
That's another area of, active discussion. Some surgeons feel strongly that pre-treating with HBO improves the take of the flap, makes the tissue healthier to receive the graft.
Better blood supply again.
Right. But others argue that with modern surgical techniques and experienced teams, the added benefit of HBRO might not always outweigh the extra time, cost, and complexity. The evidence here is still kind of mixed, according to the manual.
Okay, moving just beyond the bone itself, what about soft tissue damage around the jaw and this idea of using HBO preventatively, like before tooth extractions?
Yeah, HBRO is definitely used for related soft tissue problems in the head and neck, often alongside ORN treatment. As for prevention, like giving HBRO before pulling a tooth in an irradiated field.
To stop ORN from happening.
Exactly. It is done sometimes prophylactically.
Hmm.
But the evidence for doing it routinely isn't super strong or consistent. Studies show varied results. It probably depends a lot on the original radiation dose and other risk factors.
So maybe not for everyone.
Probably not. The manual notes some dentists feel that just being extremely careful with the surgery itself might be enough in lower risk patients.
Okay, what about other head and neck tissues, like the larynx, the voice box? Can that get necrosis too?
It can, yeah. Laryngeal necrosis. Less common than ORN, but very serious when it happens. The manual suggests, based on case reports and small series, that HBO can be helpful for some patients.
Improving symptoms, promoting healing.
Yes, potentially.
Yeah.
But it also cautions that severe cases are really challenging, and HBO isn't always a magic bullet. Similar findings, sort of mixed results from small studies, are reported for other soft tissue necrosis in the head and neck.
It sounds like the applications are broadening, though, beyond just fixing dead tissue. The manual mentions quality of life, maybe even prevention of other side effects.
That's a really interesting area. Researchers are definitely looking at whether HBO could help with other long-term radiation effects that aren't necessarily necrosis, but still really impact patients, like xerostomia.
Dry mouth, that's a big one after head and neck radiation.
Huge. It affects taste, swallowing, speaking, risk of cavities. Quality of life plummets. Some early, smaller studies hinted that HBO might improve saliva production or taste function.
But still early days for that.
Very much so. The manual is clear. More rigorous research is needed before we can say for sure if it works consistently for xerostomia.
Okay, let's shift focus down the body. Breast cancer treatment often involves radiation to the chest wall. What about delayed injuries there?
Yeah, radiation for breast cancer can definitely cause late problems in the chest wall, both soft tissue and sometimes rib or sternum necrosis.
And HBO.
The manual mentions case series, suggesting HBO can be a useful adjunct, especially when surgery is needed. It seems to help with wound healing, reducing pain, reducing swelling or edema in that area.
Beyond just necrosis, other lingering issues?
Yes, studies have also looked at HBO for things like chronic pain, arm swelling or lymphedema, and restricted shoulder movement after breast cancer radiation. Some results look promising for improving those symptoms and overall quality of life.
Is there bigger research happening there?
There is, actually. The manual specifically calls out an ongoing randomized trial in the Netherlands called the Honey Trial. It's looking directly at HBROs for late radiation effects in breast cancer survivors. So, hopefully, more definitive answers to come.
Good. Now moving into the pelvis. Radiation, cystitis, bladder inflammation. That's a known issue after pelvic radiation, say for prostate or gynecological cancers.
Absolutely, and it can cause really difficult symptoms, especially hematuria, blood in the urine.
How does HBO stack up for cystitis?
Here, the picture seems quite a bit more positive, according to the manual. Multiple case series, and importantly, a few randomized controlled studies have shown HBOs can be quite effective.
Effective how? Reducing the bleeding.
Yes, significantly reducing or even stopping the hematuria and improving other symptoms like pain and urinary frequency. Often, this is in patients where other standard treatments have already failed, so it seems like a valuable option there.
Okay, that sounds encouraging. What about the bowel? Radiation proctitis affecting the rectum or enteritis in the small bowel?
Similar story, thankfully. The evidence suggests HBOs can be beneficial here too, helping with symptoms like chronic rectal bleeding, pain, diarrhea.
Are there good studies on this?
Yes. Again, the manual mentions several studies, including some randomized trials, that showed statistically significant improvements in patients getting HBO compared to control groups.
So it's becoming more accepted for bowel issues.
It seems so. The manual notes that professional society guidelines are now acknowledging HBO as a potential treatment option for radiation proctitis and enteritis.
And this applies broadly in the abdomen and pelvis. Other organs.
The manual does touch briefly on using HBO for radiation injuries in other pelvic structures, like the vagina, again citing case series reporting positive outcomes, healing, symptom relief.
Even the skin can have delayed problems, right? Not just immediately after treatment.
Correct. Delayed radiation-induced skin necrosis can happen. Maybe an area breaks down months or years later.
And HBO for that.
Again, the manual points to case reports and series suggesting it can help heal these often difficult chronic skin wounds, even large ones.
Okay, let's tackle a really tough area. Neurological injuries from radiation. Damage to the brain, spinal cord, nerves.
Yeah, this is definitely one of the more challenging areas. Radiation can damage the nervous system, leading to things like radiation myelitis spinal cord injury or brain necrosis or optic neuropathy affecting vision.
Can HBO help with these?
Well, the manual indicates the evidence here is much less robust compared to, say, cystitis or ORN. It's mostly based on case reports or a small series.
Any glimmers of hope?
There are some reports of improvement, particularly if HBO is started early for radiation optic neuropathy. But overall, controlled studies are lacking and outcomes are really variable. It's certainly not a guaranteed fix.
The manual made a general comment about treatment length for neurological issues.
Yes, it highlighted that the approach isn't standardized. But often, if HBOs is considered for these neurological radiation injuries, doctors tend to recommend a longer course, maybe 40 treatments or even more.
Okay, so lots of specific applications with varying levels of evidence. The manual then zooms out to mention three sort of landmark publications.
Right. It flags a large registry study, basically collecting data from many different hyperbaric centers. That study reported generally positive results for treating various LRTIs.
Okay, broad positive signal. What else?
Second, a European consensus conference. Experts got together, reviewed the evidence, and made recommendations. Notably, they gave a strong recommendation for using HBO to treat mandibular ORN.
So strong backing for ORAN specifically from that group. And the third.
The third is a Cochrane collaboration review. Cochrane reviews are known for being very rigorous, and while they acknowledge the potential benefits of HBO, they also really emphasize the need for more high-quality randomized controlled trials to strengthen the evidence base across the board for different radiation injuries.
Right. The call for more robust research is a constant theme, isn't it?
Absolutely, especially for some of the less common or less studied applications.
We touched on xerostomia, dry mouth earlier. Does the manual circle back to that specifically?
Just briefly, it basically reiterates what we discussed, some anecdotal reports, some small studies suggesting potential benefit, but a real need for more solid research to know how effective it truly is.
Now, what about this idea of HBO as a modulator of radiation injury? What does that mean?
That's getting into the preventative idea again. Could using HBO around the time of radiation therapy itself, or maybe shortly after, actually change how the tissues respond? Could it potentially reduce the severity of late injuries that develop down the road?
Like pre-treating almost.
Sort of, yeah. Or maybe treating very early in the process.
Yeah.
The manual suggests this is an area of ongoing research interest, especially, as we mentioned, around dental extractions in irradiated fields trying to prevent ORN. But it's still pretty exploratory for broader applications.
Then there's this other angle, HBO as a hypoxic cell radiosensitizer, making radiation work better on the cancer.
Yeah, this is an older concept, actually. The idea was tumors often have hypoxic areas, low oxygen, which makes them resistant to radiation. So, could flooding the body with oxygen via HBOs make those resistant cells more sensitive to the radiation treatment?
Did it work?
Lab studies showed the principle worked. But translating it effectively and safely into clinical practice proved difficult. Plus, concerns were raised later about whether stimulating oxygen supply could potentially have unintended consequences on tumor behavior itself. So it hasn't really become a standard practice.
Which leads perfectly into the next point, this lingering concern about cancer. Could HBO, by promoting blood vessel growth and healing, potentially stimulate cancer growth or recurrence?
That's the theoretical worry, isn't it? Since angiogenesis is involved in tumor growth, could HBO inadvertently fuel leftover cancer cells? It's a critical safety question.
What does the current evidence say?
According to the manual, the bulk of the available evidence, which is mostly from retrospective studies looking back at patients who received HBO, does not show a strong signal that it increases cancer recurrence rates.
So, generally reassuring.
Generally, yes. But the manual rightly stresses the need for ongoing vigilance. It's something doctors need to be aware of and consider, especially in patients with very recent or currently active malignancy. It's not a concern to be dismissed lightly, even if the current data is mostly reassuring.
Okay, that's important context. Finally, the manual brings up the practical side, utilization review and cost.
Right. Because HBO involves specialized facilities, equipment, and multiple sessions, it's not an insignificant cost.
Yeah, I imagine it adds up.
It does. So the manual emphasizes that its use needs to be managed appropriately through utilization review processes within healthcare systems. And the cost effectiveness compared to other potential treatments or compared to just managing the complications without HBO is always an important factor in decision making.
Well, we have certainly covered a huge amount of territory in this deep dive. Just to try and summarize, these delayed radiation injuries, LRTIs, they're complex, they develop over time, and can seriously affect quality of life.
Definitely. And hyperbaric oxygen therapy, HBO, it clearly shows promise. Especially, it seems, for certain conditions like mandibular osteoradionecrosis, radiation cystitis, and radiation proctitis, where the evidence looks relatively strong.
But it's not a magic bullet for everything.
Not at all. The evidence varies quite a bit depending on the specific type of injury and the body location. And as we've heard repeatedly, more high-quality research is really needed to refine the protocols and figure out exactly who benefits most and when.
Yeah, for me, one of the really striking things is just how multifaceted HBO seems to be. It's not just pumping in oxygen. It's this potential to stimulate new blood vessels, reduce scarring, maybe even mobilize stem cells, all from breathing oxygen under pressure. It's quite remarkable, really.
It is. And the fact that there's still active debate and research around optimizing its use just underscores how dynamic medicine is. We're always learning, always refining.
Absolutely. So if you're listening and interested in learning more about hyperbaric oxygen therapy, or maybe about a specific radiation injury we discussed, we definitely encourage you to check out the resources in the show notes.
And of course, the most important step is always to talk to a qualified healthcare professional. Your own doctor or a specialist can give you advice tailored to your specific situation.
Yeah, definitely. This field is constantly evolving, so staying informed through reliable sources and medical advice is key.
And maybe a final thought to leave you with. As our radiation therapies get ever more precise, more targeted, how does that change the game for supportive therapies like HBO? Will we need to adapt how we use things like hyperbaric oxygen to match the evolution in radiation to ensure we're getting the absolute best long-term outcomes for patients?
That's a really interesting question. Food for thought.